Good evening, Endo Summit Live, and welcome to leg and groin pain this evening with our panel of experts. The first that we have surgeons mixed with a physical therapist, which I, being a physical therapist, and Dr. Vidali, my co-founder, being a surgeon, we think that this is always the way to go, is to mix throughout specialties. Please welcome this evening Dr. Nicholas Fogelson. Dr. Fogelson, can you introduce yourself?
Yeah, I'm Nick Fogelson. I'm a gynecologic surgeon. I specialize in endometriosis and pelvic pain care and now neuropelvicology also. And I have a practice, Northwest Endometriosis and Pelvic Surgery in Portland, Oregon. And Shanti Moling, who's another Endo Summit faculty, she's my partner. And that's what we do out here.
Wonderful. Also joining us this evening from New York is Dr. Mark Zoland. Doctor, do you want to introduce yourself?
Sure. I'm a general surgeon in New York. My specialty is groin pain and pelvic pain. And specifically, I do a lot of inguinal hernias, nerve entrapment syndromes in the groin area. So it overlaps with a lot of the pelvic pain patients.
Excellent. And also joining us, we have two West Coasters this evening, is Dr. Amanda Olson, a physical therapist. Amanda, can you introduce yourself?
Sure. I am a pelvic health physical therapist. I help manage a wide variety of different diagnoses, but endo and pelvic pain is certainly a passion of mine. And then I'm the president of Intimate Rose, where I create fun, pretty tools to help manage pelvic floor so that people can reach their goals and feel better.
Yes, also, only because I had to go through everybody's bios in case I wanted to introduce you. Amanda, you do significant coursework in running and pelvic floor dysfunction. Could you highlight some of that work, since we don't have 2 days to do a course on it, but go through like top 3 things to understand about running and your pelvic floor?
Sure. I think the top one is that it is highly possible and you can and should continue to run. Even if you have pelvic floor dysfunction, we can still help manage it. There's a lot that can be done, whether you're experiencing incontinence or pelvic pain. It affects both men and women across the lifespan for various reasons. Sometimes people forget about the men and they experience pelvic floor dysfunction too, and it can get in the way of their lifestyle and their ability to run. And there's a lot we can do there. And another one is when it comes to return to run postpartum, there's no hard and fast date as to when it is safe or appropriate to return to run. Some women are ready early and some require several months in order to prepare. So it comes down to the individual and their medical history and also how they were running prior to their pregnancy and delivery.
Right. And I always say, people like to say walk, do yoga, or swim if you have pelvic pain. And that's not always your jam. So if that's not your jam, you're not going to be consistent. You're not going to get the benefits mentally and physically of exercise. If you're like, ah, crap, I got to go out and walk. You want to, find an exercise that suits you. So for many years, we have discussed Endo Summit Workshop, having 6 workshops about exercise. We did have this little pandemic thing get in the middle of that, but 2 other people requested that. So we may revisit that for 2024. So let's talk about leg pain. I every year, our town meeting at the Endo Summit is an open mic. And at one point during the summit, there was a line, Amanda probably remembers, there was a line about 8 people deep. And we turn around and we had 6 physical therapists on the stage, and we turned around and said, show of hands, how many are asking about leg pain? And every single one of those people raised their hand. So it's very, very common. Dr. Fogelson, I know you have a specialty with the nerves, but how often do you see leg pain associated with endometriosis?
So quite frequently, I think that uterine, what I've noticed over time, like I really see sort of different neurologic patterns of pain, is that uterine pain, I think, often radiates into the anterior thighs. And I don't entirely know why, but it's a very common pattern that people that are having like dull aching hypogastric dysmenorrhea often say it radiates into their thighs, but never past the knees. And it's kind of a dull all over their quadriceps kind of pain. But then you also get somatic radiation into the legs. And so if you have pain down the back of the legs, that can be sciatic, very rarely sciatic endometriosis, but more commonly sciatic compression from vascular compressions, which can be cyclic with the menstrual cycle for sure, even though they're not endometriosis. And then, of course, any nerve that serves the legs can get inflamed if you have stuff in the pelvis. So the obturator nerve, the genitofemoral nerve, the sciatic nerve, and the femoral nerve much less often, actually, because the femoral nerve is way lateral on the lateral side of the psoas muscle. And so it's kind of hard for endo to get out there, at least it's not common. But you can get kind of a visceral femoral. I don't entirely understand how it works, but people get like a visceral pain radiating into their anterior thighs. And I'm not sure why they do, but it seems to be a very common pattern.
Yes. So Dr. Vidali, how often you're seeing a lot of leg pain? What are typically the chief complaints that you see with that? I'm not sure your mic is on, sir. Still not on. So let's talk about
Am I? Can you hear
now
me?
you're good. It is, I'm just saying we've been at this for 3 years.
No, the things died, so I had to switch to the regular computer thing. So, yeah, very similar to what Nicholas had just mentioned, is very common. And I would say that if I have to say the most common pain pattern that, I certainly see in endometriosis patients is anterior thigh pain. It's a very common finding. So, and I'm sure that our panelists will talk more about that. But if I have to say that there's one thing that I see very commonly, that's what it is.
Yeah, I think. Go ahead, doctor.
Andrea, do you think that is coinciding with dysmenorrhea, or you think it's actually? I mean, the thing that's going into the anterior thighs is femoral nerve and genitofemoral nerve, like the femoral branch of the genitofemoral nerve, really. But the patients don't describe it as a somatic seeming pain. They kind of describe it in this kind of dull, visceral way.
Yeah, correct. Yeah, I would agree with that.
Which makes me think that it's actually hypogastric. It's just being perceived in the legs for some reason.
Possible.
Yeah. Actually, we referred some of our Instagrammers to it when we had Dr. Mangishkar and Dr. Mawad on. They had a big discussion that endometriosis only really needs to be somewhat near that hypogastric plexus to begin stimulating pain into the legs.
For sure.
Yeah. So let's talk about, I think, and Amanda, as a physical therapist, people just come to you with a problem. Do you think people, it hurts below the belly button, so must be gynecology? Is that what you see frequently? Must be an organ.
When they're being referred in?
Yeah.
Yeah. Unless they've been educated, I think it's a pelvic floor muscular driver, a musculoskeletal driver. They think they've strained their abdomen, but a lot of them do think that it's being driven by the ovaries themselves.
Right. So let's talk about those nerves. Dr. Zoland, do you want to describe a little? We always call him a little bit of a groinecologist, which was his term. I asked him to trademark that. So do you want to describe a little bit of the nerves that go on and their pattern, I would say probably dermatomes or myotomes?
Sure. So essentially you start with the dermatomal nerves, which start all across the abdomen, starting at the thoracic spine. So you can have, generally we always have our reference point as T10, which is the umbilicus, that's the belly button. And these are nerves that come out of the spine and wrap around the ribs and then branch off to have an anterior branch. And essentially in a band-like pattern, you've got nerves at T10, T11, T12. And these from the belly button down to the pubis would be at the skin level, these what we call dermatomes. And what that means is just the area on the skin where you can have pain. So other nerves that sort of overlap, and this is why it gets complicated, other nerves that overlap in the area would be the iliohypogastric, which is also covering sort of the abdomen at the belly button and below, ilioinguinal, which covers the groin area, the genital branch of the genitofemoral nerve, which covers the groin area, as well as on the female, the labia majora, on the male, the scrotum and the testicle. And then as we get further down, you know, as Dr. Fogelson said, you've got the obturator nerve, which covers the medial aspect of the thigh. You've got the femoral nerve, which covers the anterior portion of the thigh. And I think to all of your points, you can get a generalized pain syndrome in the thigh and the upper leg from any kind of irritated system in the pelvis, I think. And I don't know that it has to be specific to a nerve. But if you can localize it to a nerve, you can try to work backwards to see what it is that's bothering that particular nerve.
All right, so let's do that. Between you and Dr. Fogelson, patient comes to us because the two of you, Dr. Zoland is a general surgeon, Dr. Fogelson is a GYN, and Dr. Vidali also GYN, and then Amanda is a physical therapist, as am I. So Dr. Fogelson, let's start with you. Patient comes to you and their chief complaint is really leg and groin pain. And again, I don't think a lot of patients know the groin is that inner thigh. And sometimes people call that their hip, but I do call that the groin. That how do you begin your evaluation to try to figure out what your next steps are?
Well, you know, I always want from a patient to make a very, very specific description of what they're feeling. And a lot of patients want to come in telling you what the other doctor told them, who didn't fix them, or they want to tell you what the diagnosis is. They want to say, I have pain in my ovary, I have pain here, I have pain in this organ. And I always say, I appreciate that, but don't tell me what you think it is. Tell me what it feels like. I want to know very, very specifically what it feels like. So groin pain is almost always going to be somatic, which means, so a somatic nerve is a nerve that you are perceiving, and the pain is in a very specific location. It is coming down hypermyelinated or myelinated nerves that are going to get to the brain very quickly, and you're going to have a very sharp, burning, cutting sort of pain, as opposed to a very kind of a dull aching pain, which would be more of a hypogastric or more a visceral pain. So if they're saying they have groin pain, first of all, I have to say, like, this may or may not be my area. If it's certain kinds of groin pain are going to be, but other kinds are really going to be more for a hernia surgeon potentially. But I really want to know, does it have anything to do with their menstrual cycle? I think that's really important. Like, if it truly is unrelated to their menstrual cycle, then I think it's very unlikely to be endometriosis related. People can have constant pains with endometriosis, but it's going to get worse during their cycle. If it doesn't change at all with their cycle, it's less likely, very unlikely to be endometriosis related. That being said, just because it changes with their cycle doesn't make it endometriosis. Like, if you, just as any woman may know, when you're on your cycle, a lot of times you retain a little bit of fluid. Any area where a nerve is going through a real tight channel, that area, if it swells a little bit, you can get a compression in the nerve, and it's not from endo, it's just that all spaces in the body are getting a little tighter. And so if something is really, almost compressed, then it may become compressed in those few days. And with the groin, like, I don't see so much groin. I see more back of the leg cyclic stuff, which is more sciatic in origin. It's kind of where I get really into detail. I also want to do a neurologic exam. So I'm going to get a very detailed history, but then I'm also going to try to do a very detailed neurologic exam. The groin nerves don't have a lot of motor function. So there's not a lot of motor. The only thing that the motor function in the groin nerves is, well, in the woman, it's nothing really. Like, the genitofemoral nerve has no motor function. It does have some sensory function, which in turn makes the pudendal nerve kind of pull up the perianal skin, which is a sort of reflex you get. So it's really all sensory. You're going to look at those dermatomes that Dr. Zoland talked about, and I'll have the patient, I'll feel the area of the nerve on the inner groin, on the front of the legs, on the labia, around the anus, and ask them if it feels different from one side to the other. If something may poke with something a little bit sharp, see if they really feel as much pain as you think they should. I mean, usually someone's going to feel pain if you poke something sharp, but if it doesn't feel as sharp as it does on the other side, that may be a loss of function in that nerve. Ultimately, their description should be pretty descriptive, even without any testing. Like, if they tell you where it hurts, you should be able to just pretty well say which nerve it's coming through.
So Dr. Zoland, how do you differentiate what pain is what pain? Because and I'm going to ask Amanda the same question afterwards, but it's a soup, because once you're in pain, everything is turned on, and it's hard to tease out what's what, and then how to make decisions on what to do. So how do you approach that?
So for me, I think the conversation, the history of what they're feeling is insanely important. And the reason for that is they may come in an extraordinary amount of pain, and doing a physical exam is useless because everything that you touch hurts. But when you break down what's been going on over the last weeks, months, years, and you get very targeted on the questions, what makes it worse? What makes it better? What position makes it worse? Are you in pain when you're standing? Are you in pain when you're walking? Is there a certain way you're sitting that you're in pain? All of these things are clues for me and for all of us as to what may be the driver of the pain. And ultimately, I think really honing down, and I think what Dr. Fogelson said is exactly dead on correct. I don't want to know what somebody thinks they have, and I don't want to know what other doctors have told them. I just want to know what somebody's feeling, and then I'm going to work backwards. So, sample questions that I'll be asking are, if somebody's got pain in the groin, let's say, and I'm thinking maybe this is a hernia, my questions are going to be, well, is it worse when you're standing? Is it better when you're lying down? Because that's characteristic of a hernia. Is it better at the beginning of the day? Is it worse at the beginning of the day? Do you wake up in pain? Do you wake up feeling good, but as the day goes on, the pain gets worse? All of this goes to kind of the soup that we're talking about that goes toward what we're trying to figure out in terms of what the pain syndrome is coming from. And you're essentially starting at the end point and working your way backwards, but getting amazingly specific for me is probably the most important part. And then we go into the diagnostic imaging, which, we can get into or not, but that's where I'm going to be starting.
Great. We're having some sort of feedback. So I'm just going to ask everybody except for Amanda to mute. So Amanda, what is your approach to a patient that comes to you and basically just says, I have pain, and points to their legs?
Generally, I would do a screen of all of their range of motion of their spine and their hip from an orthopedic standpoint. So I'm looking to see if it's possibly driven from an orthopedic factor. And then as my role as a pelvic health physical therapist, I'm questioning them and taking a thorough history about their menstruation, their bladder habits, their bowel habits. Are they experiencing constipation? Are they experiencing chronic diarrhea? What the menstrual cycle is like, if they're having pain with intercourse or tampon use. And then from there, going on to do an assessment of the pelvic floor muscles to see if there's a potential driver there as well. Generally, I'm watching too how their abdomen is behaving by screening that to see if they are experiencing diastasis rectus abdominis, which could be leading to changes in how they're moving throughout their day that could also be lending to some of those leg symptoms as well. And then, of course, screening to see if I can reproduce any of those symptoms while I'm doing the exam.
Right. So while we're staying on the groin, before we move to the sciatic nerves, Dr. Zoland, do you want to describe the three major different types of hernia that occur in the legs and what their symptoms may be? I also forgot the most important question, which I'll ask next. You have to unmute.
So the inguinal hernia is the most common hernia that we see, generally both on males and females. And that would be something that's using a reference point, I'm going to use the groin crease. And what that means is where the leg meets the body, that crease is essentially a landmark for us. So if the pain is coming from above the groin crease and shooting towards the labia in the female, that's going to be something that's consistent with inguinal hernia pain. If it's a femoral hernia, it's going to be pain on the anterior thigh below the groin crease because it's a hernia that's impinging upon the femoral nerve. And then if it's inner thigh pain, specifically, that's going to be something like an obturator hernia, where the hernia is impinging upon the obturator nerve, which covers that area. So those are the three different hernias that we generally see. And then the belly button hernia or the umbilical hernia is pain that's generally going to be right around the belly button.
And it's interesting, do you see a lot of obturator hernia type pain in this particular population, in the pelvic pain population?
You see a lot of inner thigh pain. Is it always due to an obturator hernia? Absolutely not. As we were talking about, anything in the pelvis could be irritating the obturator nerve, and it doesn't have to be a hernia. But if you're narrowing things down and you get a specific MRI with specific views, you can localize obturator hernias. And then the question is the source of pain coming from that obturator hernia if somebody has one? And then you generally want to diagnostically test that theory by doing injections to see if that makes the pain go away. And if so, then you can go ahead and fix the obturator hernia. But sometimes you're doing cases where you're doing an inguinal hernia and you just see obturator hernias that are there. And at those times, you have to make a decision as to whether or not to fix them.
Yeah, I think typically with that obturator hernia, it's that pelvic floor from the physical therapy perspective. It's that pelvic floor that you can never get to release and move no matter what you do, no matter what any GYN has done. Those are the people I like to at least be evaluated. Not necessarily, that doesn't mean just because it's there that you have to fix it. But it could mean that it needs to be fixed. So the other thing, I forgot this before we move on. Do you need a bulge to have I think because we accept it already, but a lot of people think that you need a bulge to have a hernia. Is that true? And why, or what can patients do to advocate for themselves about that?
Right. So it is absolutely not true that one needs a bulge to therefore be diagnosed as having a hernia. You can have smaller hernias that don't cause a bulge. The inguinal hernia would be the one that most frequently has a bulge. But if you don't have a bulge, it doesn't mean you don't have an inguinal hernia. And physical exam and imaging is what really gives us clarity on that. And then for a femoral hernia or an obturator hernia, you're almost never going to have a bulge because that's a hernia that goes down into the leg. So really, you don't need a bulge to have a hernia, but you do need a proper imaging study, and the person reading it should know what they're looking at to be able to diagnose these things.
I have a quick question for the panelists. Way too many patients end up getting, you just mentioned hip pain that gets really confused. I have way too many patients that get evaluated, even sometimes operated on for hip related problem when indeed it's not a hip problem at all. Do you guys want to comment on that?
Go ahead, Dr. Fogelson. Unmute.
Absolutely. So when it's like, it's only the 4th or 5th year we've been on Zoom. So the, when people ask hip pain, the first thing I do is try to assess, is there some history that would lead to them to have actual hip pain? Like, have they lived a life that would lead to them to having early or early arthritis in their hip or something? Because I mean, people can get legitimate hip injuries, obviously. So you can't just, sometimes you go like, oh, it's always referred pain. It's like, no, some people injure their hips also. But if they truly have hip pain, you should be able to make it hurt by manipulating their hip. Like if you're moving their leg and you move their femur and their acetabulum and you kind of can, manipulate it. If it's really in the joint, you should do something that should be able to make it hurt, I would think. And I'm not an orthopedist, but I tend to think you should be able to create it. But what's really important is that the capsule of the hip has got a complicated innervation. It's innervated by 3 different branches of portions off the sciatic nerve, portions off the femoral nerve, and also portions off the obturator nerve, believe it or not. And so you can get hip pain from lots of different nerve issues. And most commonly, I think people have sciatic irritation in the area of like the superior gluteal nerve. They'll often say it's my hip that hurts. And if you have endometriosis along the sidewall, just underneath the ovary, and it's sort of deep, that's often going to present as hip pain. And I have my own little surgical finding. I kind of I hate eponyms, so I always joke that it's Fogelson sign, but I'm never going to call it that because I hate eponyms. But the sign is basically like as you dissect the peritoneum off of the inside of the pelvic sidewall, there should be plenty of like insulating fat there, such that you don't create any kind of nerve action when you do that. But in some patients, you start to dissect the peritoneum away,
and suddenly their obturator nerve is firing. And what you know is that they've got fibrotic tissue between the peritoneum and the nerve is carrying the energy. Because if it's just healthy fat, it's very insulating and the energy won't get to the nerve very easily. But sometimes you're 2 centimeters from the nerve and it's the leg is jumping every time you use your monopolar, and you know there's disease between what you're doing and the nerve. And so then you know you got to go deeper and deeper until you're down onto completely healthy fat. And so I always joke with my fellows. I say, like, hey, that's Fogelson sign. That's, you got to get low, get deep into that. And I don't know, obviously, I'm sure other surgeons have noticed the same thing, but I'd never heard anybody tell me that. So I kind of made my own rule, but it very well may be something that a lot of people know about. But your hip, that same stuff, if there's disease on the side on the pelvic sidewall, it could definitely hurt the hip in the same way.
I think, Amanda, there was a time where anytime an MRI saw a labrum tear, well, there you go, there was your problem. I don't actually think it is few and far between the patients that I've seen that the pain is actually coming from the labrum. Though I was sent home, all your pain is from your labrum, go away. And it really wasn't from my labrum. So what do what's your thoughts on the labrum generating pain?
Absolutely. I think, if they have impingement and they're getting signs on that orthopedic exam, like Dr. Fogelson was just describing, it's plausible. But the interesting thing is a lot of them are also experiencing guarding and overactivity of the pelvic floor on the opposite side as well, either secondary to or just as a byproduct of having multiple disease processes. So oftentimes they are also getting obturator internus muscle tension or spasm, and then levator also. So it's really interesting to see if we can manage the pelvic floor first and see how they do conservatively, and to see if they can manage their lifestyle dependent on, what their goals are. If they're looking to be an avid cyclist or a runner and it's bothering and getting in the way, it may be worth having them evaluated by an orthopedist. But certainly I do see with impingement of the hip, that can be a very primary driver. And all the pelvic floor physical therapy in the world was not addressing that exact pain. We were addressing bowel and bladder and those kinds of things, but really it did end up needing to be managed surgically.
Yeah. Go ahead, Dr. Zoland.
Yeah, I think we do have to be careful though in aligning the hip as a diagnosis, because I go to a lot of the hip conferences, and I have to tell you, the hip is wildly complicated, and it's not just as simple as there's an impingement and there's a labral tear, and yeah, those things happen and those are fairly straightforward on physical exam. However, there could be anteroversion, there could be retroversion, the pelvic incidence, meaning the tilt of the pelvis in any individual. All these things play a role in pain in the hip joint. So I think, our job is always really to try and hone in on, and that goes back to the intense questioning that we all do of our patients, to try and really tease out, do you have pain when you're sitting? Do you have pain when you internally rotate your leg? These are things that could be signs of hip impingement or a hip process. And then the other thing that I've noticed over the years is that when somebody's hip is really inflamed, everything is inflamed. The entire pelvic floor, they're getting symptoms, from pudendal neuropathy type symptoms. And they're getting, other symptoms that wouldn't necessarily be specific to hip, but because everything is so inflamed, it gets sort of, off the charts in terms of bleeding into our different diagnoses. So I think the key is to try to figure out, is this a hip generating problem, or is it something that's mimicking the hip, but we really need to look elsewhere? So I think, and this is where it gets complicated, I think we all need to be aware of all the different diagnoses. And that's why talking to each other about all this is epically important, because I think if you're not aware of these different diagnoses, you're never going to send your patient to a potentially correct person to make the diagnosis in helping them. So I just want to be careful about saying, the hip is overdiagnosed. It is, but that doesn't mean people should walk away from this conference thinking, they told me it was hip pain. I'm sure it's not hip pain because of the conference, because I think it's really
Sure.
important.
I mean, there's an entire field of orthopedic surgery that's based on disease in the hip. It's real.
Right.
That's what a funny joke. I wanted to make a picture one day of like a big bookshelf of books where you have one big book that says endometriosis and then like 50 books that say not endometriosis all the way across, because I think that as crazy and wild a disease as endometriosis is and all the symptoms that it can cause, there's mega textbooks of all kinds of disease states that the body can have that aren't endometriosis, and sometimes people want to put at the feet everything of endometriosis because, of course, endometriosis is the praying mantis that can do everything. And it's like, yeah, but it's not necessarily always endo. The other thing I wanted to mention, Mark, you were making a great point that when one nerve gets really, really activated, other nerves start getting recruited. And I've had people tell me, no, it doesn't work that way. And it's like, no, it absolutely works that way. And I'll tell you why. It's purely electrical. The nerves are electrical wires. They're organic electrical wires that are using, rather than going to the power plant, you have biological batteries sending current up and down the nerve. And yet they're all connected. So if you have a nerve that is sending a really strong signal, so a very, very frequent signal, let's say that it's going up the genitofemoral nerve, you may start getting pain in the iliohypogastric nerve or the ilioinguinal nerve, because when that nerve gets to the spinal cord, they're actually very close to each other at the spinal cord, and they're connected. Not only they're running next to each other in the spinal cord, and the current can jump between the axons most likely, but also the sympathetic chain brings those ganglion together before they enter the spinal cord. So there is a electrical connection that would allow, if you have a strong enough current, some of it's going to leak out and end up coming through other branches. And you just see it over and over and over. And from a purely like electrophysics point of view, it makes sense that if you have a really strong signal, it's going to start jumping into other sensory nerves.
Yeah, I think the future we explore is not endometriosis in one place, hip dysfunction is in one place, but in that everything is feeding a system that generates pain. And this is now the second live where someone has brought that up, that, once one thing is injured, it's like an explosion went off. We have a lot of questions about surgical approaches coming off of Facebook. Can all of the things that drive this kind, I feel like Dr. Vidali showed up, but he hasn't been speaking very much. What do you see all of this at surgery? A typical endometriosis surgery?
No. I mean, from my point of view, this is just my own point of view, is that if I'm going to get involved in nerves in a surgery, I should be knowing I'm going to get involved with it before I ever go to the OR. That I don't expect to like encounter nerve involvement with endometriosis. I should know about it. And I don't mean from imaging either. The patient's history should tell me that their nerves are involved in some way. Probably the one bundle of nerves that is going to get involved that I'm just going to see would be the hypogastric nerves, which are the visceral nerves coming up off of the uterus and the bladder and the bowel. It's kind of under the uterosacral ligament. But something like a sciatic nerve endometriosis, you're never going to see it. You're never going to know it's there unless you go look for it. You might see it on an MRI, but you may not, even if it's there. An obturator nerve involvement. If you have an endometriosis like in the deep in the ovarian fossa, and it's kind of sucking back up into the perivesical space, you might think that it's going to be up against the obturator nerve, but ideally, you have a history ahead of time that says that this patient is having cyclic pain on the inside of their leg, and they may even have a hypersensitivity where the skin there is hypersensitive, or maybe they even have motor function loss. If there's endo that's deep enough there that it's actually started to damage the axons of the nerve, you might have a loss of motor function. Like, you should know that ahead of time. And I think sometimes people simplify it. I have patients call me that say they had excision surgery with someone and they're still having pain, and they want to call me because I'm the nerve guy and I'll be able to solve the problem. And I'm like, I mean, that may be true, but that may or may not be true. But it's really, it's all about asking the questions. Like, if they give you an answer that says that they have an irritation of a specific nerve, and then that no one explored it surgically, then you think that, yeah, maybe there is something to do there. But you can look in and peel endometriosis off all kinds of stuff, and you're not seeing nerves unless you go look for them for the most part.
Dr. Zoland, do you typically see, well, you don't scrub in unless you have to, but in a typical endometriosis surgery, are people going to pick up these fat compressions against the nerves?
Not unless they're looking for them, so a lot of times you really, if the endometriosis surgeon says they didn't see that there was a fat compressing hernia or something like that, it doesn't mean it wasn't there. And again, this is where the imaging is really, really useful, because, oftentimes we're going to find that there were hernias in these canals on imaging. But unless you're going specifically to look for them, the obturator hernia, for example, is deep down in the pelvis, and most hernia surgeons aren't even going to go there. But if I see that in the pelvis, on the imaging, I'm going to go there, because I want to make sure I'm not leaving any stone unturned, so to speak.
Dr. Vidali, you look like you're ready.
No, I would argue that in terms of surgery, there's still a lot of work to be done with surgeons preserving nerves, so that's already like something which we're working on to try to make sure that people actually develop an awareness that nerves are there, especially you're talking about the hypogastric plexus being one example. So one first thing is that. And I would say in terms of seeing nerves or having a greater awareness, in my case, it's certainly in reoperations, because in reoperations where people have had surgery already, you're going to see a greater amount of post-surgical fibrosis, reactive fibrosis, and therefore there's a greater chance of nerve impingement or invasion, by the fibrosis, and that's really where you go looking for the problem. I would say, I would argue that those are the cases where one has greater awareness, rather than in a primary excision where it's rare that you're going to have like nerve invasion directly. But when you see that post-surgical fibrosis, sometimes it's idiopathic. I mean, just a reaction to the surgery, and it can be quite significant.
Yeah, let me throw something else out. Something that I learned, I was just recently at my further neuropelvicology training in Zurich, and something that I really learned in that training was this idea of very delayed fibrosis after an injury. I used to think that someone says, I have this nerve pain, and then I say, did you ever have an injury that would have caused that nerve pain? He said, oh, well, I fell on my butt 10 years ago. And I said, well, did the nerve pain start then? And they said, no, I mean, I hurt my butt, but 6 months later, it didn't hurt anymore. And I didn't have the nerve pain for 10 years. And so I used to say, oh, well, it doesn't have anything to do with it. I mean, if it would have hurt the nerve, it would have hurt the nerve immediately. It turns out that's wrong. So if you have an injury that creates a lot of a hematoma or maybe an infection that's going to involve a nerve, that process of fibrosis can happen over years. And a patient, let's say a patient has a vaginal birth and she has a big black and blue labia after a birth because of a forceps delivery or something. Well, that space is contiguous with the entire pelvis, like her sciatic nerve, her obturator nerve, her sacral nerve roots, depending on how far it goes up, all that stuff was covered in blood. Like it didn't just stay under the skin, it was all contiguous with that. And so that patient 7 years later develops pudendal neuralgia with no mechanism of injury. She doesn't sit on a thing. She doesn't like sit on bikes all the time. She's not a horseback rider. She had no other injury. You know how she got pudendal neuralgia? It's like that delivery 7 years ago took 7 years to get enough fibrosis to be compressing that nerve. But that is probably how she got pudendal neuralgia. And it's very interesting to me because 2 years ago, I never would have operated on that patient because I would have been, how could this have had anything to do with it? And now I've kind of learned, oh, this delayed fibrosis thing is real. And then you go and operate on them. And sure enough, in that area, the fat's all sticky. Like instead of having the fat be all kind of just soft, you operate and the fat's glued to everything. In fact, I operated on a patient today she actually has an axonal loss in her sciatic nerve. Her her ankle won't push down very well. And on that sciatic nerve, the fat was just glued to everything, as opposed to being just pushing it off the nerve. It was like everything was just stuck. And it wasn't endometriosis. It was something happened at some point in her life that filled that area up with blood, probably. And, you know, I lysed it all away, and, you know, we'll see how she feels. I don't know whether it'll work or not, but I think that's why she was having these symptoms. And I think that's why her nerve wasn't working right. So, you know, the history doesn't have to be 6 months, you know, it doesn't have to be at the moment the pain started. It could have been 10 years before, earlier in their life.
Amanda, any commentary on that? Because you have some background in those
Falling
types
on
of
one's
things.
bottom.
Right. Falling on one's bottom.
And managing those who have fallen on their bottom. Yeah, it's that's so interesting to hear that there can be a delayed onset. I think that's really fascinating, and it certainly opens our eyes to, you know, possible why, you know, and sometimes when it is insidious, it can be harder to tease across. And if we're not able to reproduce it on a typical pelvic health exam, it creates that need to quarterback, like they were saying, to identify where we might need to be sending them to the appropriate surgeon in conjunction with their care team, so that they can be getting more answers.
Yes. So go ahead, Dr. Zoland.
Right. Going along with this conversation is simply that I have a lot of people that really want to know the why. You know, why did this happen? Why did it happen now? And I think that you know, a lot of time I answer, if it's a remote injury and it happened many years later, it's about critical mass. There at some point, the nerve gets irritated enough with a critical mass of whatever it is, whether it's scar tissue, endo, mesh from prior hernia surgery or something like that. It doesn't have to be exactly at that time. And I think, you know, what you guys are saying is exactly dead on correct, that you really have to get the entire history. And even when you don't have an actual moment of trauma, there's definitely things that people have that they don't even know that they have. Example is, you can have somebody that has a medial hamstring injury because they're a runner. They don't know that they have it. But when you look on the MRI, there's some scarring there, and that can entrap the posterior femoral cutaneous nerve, and they can have buttock pain. And this is something that, you know, they didn't know that they had some type of a hamstring injury. Some people don't know that they have a hernia. I mean, all these things can happen. And you know, that's why on the one hand, our jobs are so difficult, because sometimes you don't really know the instigator. But the flip side of that is, we have to know our stuff, and we have to be able to work backwards to figure out as best we can. I mean, there are just some times where you can't figure it out, you know, but you have to be able to work backwards and figure out what nerve do we think is being irritated, and then try to figure out what is it that's irritating the nerve.
The other thing, if I don't mind just to add on to what Mark just said, is that I get a lot of not referrals, but patients come to see me, and the patient has a very specific pain, and the previous doctor maybe even could have recognized what nerve it was coming up, but they're like, but I don't know what it is, or I don't know why, or I don't know, so forth. Part of kind of my approach from what I saw in neuropelvicology stuff is like, if you can identify which nerve the pain's coming through, somewhere along that nerve, there's a problem. Well, it may be, and when I say somewhere, I mean all the way up to the thalamus in their brain, all the way down to the end of that nerve. But there's a problem somewhere. And if a patient has sciatic pain that's radiating down to the bottom of their foot, and it's going up the outside the back of their leg, they have S1 irritation somewhere. Like it could be even in their leg. Like it could be they've got osteosarcoma in their femur, and it's irritating the posterior tibia, the posterior femoral nerve there, or popliteal nerve. Like I've seen that. I saw a patient that had sciatic pain that literally she had a tumor in her leg. So that was one weird thing. But somewhere along the nerve, something's going on. And so I think that as gynecologists, or as anyone in this kind of area, you should feel free to kind of like get outside your box a little bit. Like I order lumbar MRIs sometimes. I've even ordered brain MRIs when I thought, this doesn't make any sense. Like there is something going on, and I know the pathway it has to be on. And I've looked at this area and that area. It says, well, these other areas I haven't looked at, let's look at it. And maybe we figure it out, maybe we don't. But I think that sometimes the history is very specific about a narrow box of things where it has to be in that box somewhere. And at some point you should just check everything that's in that box, because you're probably going to figure it out.
The great dilemma in what we're doing in the area of endometriosis, one of the great dilemmas, in my opinion, are people who have experienced multiple operations and who have had everything taken out, hysterectomies, like, there's no more gynecological organ left, right? But the pain's still there. And, there's always the assumption that there's going to be some scar tissue there. And so one of the big dilemmas there is this, where, these people end up having more and more surgeries, sometimes just exploratory, random, sort of like, fishing expeditions, for lack of a better term, without really a targeted approach. And I think there's a lot of that going on. And I think it's an area that needs to be discussed, because sometimes these are clearly the cases where perhaps there could be, but most likely there may not be a surgical solution in these cases. And so those are difficult cases, I think.
Right. And it's very important to say that happens to us too. That happens to Andrea. It happens to me. I think I'm good at what I do. I think Andrea is good at what he does. I can name 10 other surgeons who everyone would say, yeah, that person's a good surgeon. It happens to all of them. Everyone does surgery everyone who does really good surgery has patients that have recurrent pain. And one of the mythologies, I think, that kind of is out sometimes in the advocacy community is the idea that if someone has recurrent pain, the surgery wasn't done well enough. And I think that's nonsense. I mean, I think that's true for a subset of patients. I think a poorly done surgery is going to be more likely to have recurrent pain. But I think you can do the best surgery that any human surgeon can do, and patients can still have recurrent pain. And we don't always understand it. And there's not always an answer. Like I tell patients, if they're 75% better from the surgery, it's very successful. And if they chase 100%, you may be chasing forever. I just want them to have a quality of life that's better. And if they have a functional, good quality of life, then I'm less interested in just continuing to try to pick out 2 more cells of endometriosis, because I doubt that's what the problem is. And the other thing is that if it is a nerve entrapment from scarring from endometriosis, it may or may not be helpful to go try to operate on that, because, I mean, you might get it better for a while, but then it's going to scar up again. I was talking to Mark Possover, is, this nerve guy in Switzerland I've studied with. We were talking about how when you strip the peritoneum out, you're effectively doing a neurectomy of the peritoneum, like that the peritoneum is innervated through tiny little somatic nerves. There's all these little fibers coming up from the retroperitoneum that are going into the peritoneum. And when the endometriosis is there inflaming it, you're getting a somatic pain. I mean, there's probably dermatomes in the pelvis that no one's ever mapped, but there's probably peritoneal dermatomes. And sometimes I think that the endometriosis, the pain's coming back because it's just getting reinnervated, and that you've totally stripped the peritoneum, and now initially you get denervated, regrown scar tissue, and then eventually there's new nerves growing into this new peritoneum, and it hurts again. And you see the same thing if you were to have a really bad burn on your skin. Like initially it wouldn't hurt at all because you've just burned the nerves, and then eventually it starts going through this whole neurogenesis again. And I have wondered if there were some sort of solution you could put in the pelvis that retarded nerve growth, could you keep people from having recurrent pain as much? And God knows what damage that would do anyway. I mean, it's a fantasy, but it's not always just there is something neurologic going on in recurrent pain, and I don't have the answers, but I think it's more than just that someone left some endometriosis behind or that it grew back.
Well, I think as an entity, the Endometriosis Summit has always tried to teach, like, it's not just about have a surgery, have another surgery, find the thing. And as a clinician, that's the sign of maturity. When you're, just learning how to do pelvic PT, it's always like one little, find the thing. But in actuality, healing isn't like that. And it'll be interesting. We have a workshop this year on acceptance. Acceptance may mean loving the person that's 75% better and letting go of the expectation of being 100% better. That doesn't mean don't go live your life and don't go have a healthy, enriching life, but it's accepting a different life that can be equally as good. I diverged. I want to go through some of the questions. We did not get to, and I'm not going to throw it in here to do it with 8 minutes left. We want to talk about what Dr. Fogelson and Dr. Zoland does it. Some understands it quite well. Some of these vascular compressions. I think we don't talk enough about that. We're going to set that aside either for another webinar or for an Instagram live if Dr. Fogelson's staff ever lets him on social media again. So, which we were discussing.
I still do it.
Yeah. So, but fascinating new work is that that in the vascular compression area. So we have a very good question here on Zoom, which is, you know, we're all specialists, but most people head to their primary care when they want to be evaluated for this. What are questions to ask the primary care and expectations they should have out of a primary care to be able to talk about these nerve-related issues? Go ahead, either one of you.
I'll take this one.
I don't even know. It's a good question. Go ahead, Mark.
Yeah, no, it's a good question. I mean, I think number one, it's tough. And I think that the reason why it's tough is that some primary cares have no idea what you're talking about when you, I mean, yes, primary cares know endometriosis, and yes, they know hip impingement, but when we're talking about neuropelviology, or we're talking about an obturator hernia, which is not something that they would even remember from medical school, it may be completely outside their, just their daily interaction with patients. So, and that doesn't make them bad, and it doesn't make them, not still the GP that you love. But the truth is, it falls upon you. So when you ask your doc a question and your doc sort of has this blank stare, like, I don't know, or, I think this is in your head, or, what about seeing a psychiatrist? Because, we've already sent you to the orthopedic surgeon and they didn't find anything. And then we sent you to the general surgeon and they didn't find anything. And your gynecologist says it's not endo. The truth is, at that point, it's time for you to look outside of your internist, right? And part of this is doing your own research. The internet these days is, it's sort of full of good information and bad information. But I think a lot of people have gotten very good at sort of teasing out the good information, just like you're teasing out a good restaurant. You take some of the ridiculous reviews and you put them out there, you stick them on the side, and, you just really have to do your own research. And then, what I tell patients in other states sometimes is, look, call the university centers, ask, call the secretary in the department and say, do you have anybody that does this? Or do you have anybody that deals with that? And at times you pave your own pathway in that direction, or at least you find the person that could then point you in the right direction. And, this is unfortunately where it goes sometimes, but for people that are kind of isolated in those communities that don't have people that are, understanding of this part of the body, the pelvis, the groin pain, you're probably going to need to do your own, road work there.
Anything else to add, team?
Well, I mean, one thing that Mark said, which was very, very generous, was that the primary care physicians know endometriosis, but we all know that they really don't. Like general gynecologists hardly know endometriosis. I mean, the amount of education.
Mark's a nice guy. He doesn't like.
I know, like the it's funny that the people that really seem to be that think about endo a lot are more commonly PTs and naturopaths than general gynecologists. I think that when the general gynecologist wants to think, as soon as they diagnose the patient with endo, they think it's going to be a headache. They don't want to get into it because they think it's going to be their problem if they make it the issue. Whereas the PT knows they're going to have to, if it's a surgical issue, they're going to have to refer out, and the naturopaths do too. I'm just like, I don't know. I've just noticed that like a lot of naturopaths seem to consume a lot of endo information and seem to know, they think of it far more than a lot of people do. And
Well,
maybe it's just the one, maybe it's just the ones in my town, but
I
see it a
look
lot.
at it this way, that a naturopath or a physical therapist, they get an hour to listen.
Yeah, yeah.
I mean, I went to a primary care and handed a surgical report to them, and they said this doesn't happen to anyone. So like, I mean, they only have those 10 minutes that they're spending in front of a computer. It's not that there's ill intent, it's that they don't have the time. So my next question, which I want to get to, Amanda, I actually think that comes to you. That feedback comes from your headphones somehow.
Oh no, sorry.
So let's talk about, it'll be interesting to see added into the summit this year. We're going to do a whole hour on foot and pelvic pain with Leela Abad, who's an orthopedic specialist. How often, Amanda, do you see the pain coming from the floor up instead of the pelvis down? Because we have a question about that.
In terms of how often, I would say maybe roughly 30% of patients with pelvic floor dysfunction are also having some foot or ankle restrictions or hypermobility even, or limitations in their metatarsal phalangeal joints, so the toe joints themselves, that are lending to walking and moving and squatting in a way that is also disrupting or leading to some changes in the pelvic floor as well. So I always evaluate and screen the feet as well.
Yeah, so, and we're going to talk all about that evaluation at the Endometriosis Summit. So we have 2 minutes left. And in those 2 minutes, first of all, I want to, each of you, we could go live and discuss, everything we talked about for hours on end. So I want to invite everybody back, and we'll talk a little bit about that.
Sallie, if you want to run over a little bit, I don't mind talking about the vascular stuff after if you want.
I do want to run over. I don't like to assume that I can eat up everybody's time.
No, I will.
Yeah. So then let's move on into that because it's fascinating.
Unfortunately, I'm going to have to leave though. So I'm just going to say goodbye to everybody. Sorry, I had something that I have to run to, but thanks guys. It was a very stimulating conversation. Really enjoyed it.
All right. So let's talk about vascular. Now, I just want to know, what does that do for our bet though? Do I get like a percentage back on our bet there with him? So
Not at all. He was
not
here
at
for-
all.
Yep.
Not at all. Okay. So Dr. Fogelson, talk to us a little bit about vascular compressions.
So let me preface this by saying that like 15 years ago, when we're talking about intrapelvic vascular entrapments, about 15 years ago, Mark Bossover showed a video of doing a case like this, and no one had ever seen it before, and they thought he was insane. And it has slowly become something that some people are aware of, and probably a handful of people in the world are really trained to deal with. So it's like you can talk about it, but there's really very few people that surgically have trained in how to deal with these things. Like I'm one of them, and I'm not saying that to like toot my horn. I'm saying it because just because we can talk about it doesn't mean that there's that many people that would dare to try to fix it. But what we are talking about is that the vascular system in the body follows a certain pattern. Your arteries are almost always the same. Like for the most part, the arteries of every human being are running in pretty much the same locations, but our veins are not. So when you get to the really big veins, they tend to be all the same. But when you get to smaller and smaller veins, you see lots of different configurations of veins. And it turns out that sometimes the veins get placed in a way that is putting compression on nerves. And there's a couple of different things. So one of the big ones that we see with cyclic sciatica is that there's a superior gluteal vein that is pinching the sciatic nerve into the sacrum. If you look at about 90% of people, the superior gluteal vein, which comes off the internal iliac vein and it goes into the gluteus, so it drains blood out of the butt. That vein goes underneath the sciatic nerve in about 90% of patients. And so in that circumstance, you have the sacral bone, you've got the vein, and you got the sciatic nerve running on top of it, and there's nothing on top of the sciatic nerve. So when the vein gets bigger, it maybe pushes the nerve up a little bit, but it's not compressing the nerve. Well, when you look at anatomic studies, about 10% of the people, the gluteal, if let's say this is the side of the pelvis, and here's a sciatic nerve, the gluteal vein is running over the top of the sciatic nerve into the gluteus here. And then underneath is just bone. You have the back of the sacrum. And so now you have the nerve getting bone underneath it, vein on top. And if the vein happens to be configured in a way where it's just pretty much tightly wrapped around the nerve, then any condition that's going to get that vein to get big and bulgy is going to compress the nerve. And if you compress a nerve, initially you're going to get numbness. You can do it yourself. You can sit on the toilet too long. You can start compressing your sciatic nerve, and initially you'll get numbness. And if you do it long enough, you get pain, and you'll also get motor dysfunction. Like you sit on the toilet long enough, you'll paralyze your sciatic nerve, and it won't work. And you stand up, and you're like, well, my leg's behaving weird because your femoral nerve is working, but your sciatic nerve isn't. So it's possible for there to be veins that are compressing. It's also possible for a person to have varicosities in their pelvis. So when we talk about people that have pelvic congestion syndrome, really what that is veins that are incompetent. And in medical terms, incompetent means that the veins are allowing blood to go backwards. So really, the veins should have all these valves in them, so the blood will only go up. And as it moves past the next valve, it doesn't come back. So in turn, the blood always gets back to the heart, even if it's going against gravity. But sometimes people's veins just don't have the right valves, or they're stretched in a way where the valves are not coming together well. And then the blood is sort of pooling in the pelvis. And if you look, I think that everyone talks about pelvic congestion syndrome like it's all about the gonadal veins, the ovarian veins. And I think that's just because the concept of the deep pelvic veins is just, no one has any idea. It's like when you go and operate in there, the internal iliac vein has this huge network of veins, and they can wrap right around the sacral nerve roots and around the sciatic nerve. So I think when people have pelvic congestion syndrome and they're having sciatica and they're having pudendal neuralgia and they're having glutealgia and they're having a spastic pelvic floor, they may have a vein that is compressing. Like if they're having like a spastic pelvic floor, they may have a vein compressing S2 and S3. And they're going to have pudendal neuralgia also, and they're going to have urinary urgency because the pelvic splanchnic nerves are being affected. And so what it turns out is that, again, if you can go through that diagnosis and figure out what nerve is getting irritated, and then the patient says, well, when I stand up, I get this symptom, and then when I lie down, I feel better. Then you start to think, well, why is that? When you stand up, those veins are going to get bigger. You could also say if they exercise, so they start moving a lot, that's going to get more blood flow going through the pelvis. Does it hurt more? Also, people with vascular compressions in the pelvis, it gets much worse during their period, which makes them think that they're having, endometriosis, when really what it is that it's drawing more blood through these veins. They're getting bigger and they're compressing more. Most importantly, one of the big differences between sort of a vascular cyclic pain and a endometriosis cyclic pain is that a vascular pain gets much, much worse as you're getting up into before the premenstrual period, up into the bleeding. And then as soon as the woman's bleeding starts, it generally gets better. Whereas if someone has endometriosis on a nerve, it's going up into the period. And then when the period starts, it just goes through the roof. So they get even worse. And so when patient says, oh, I start feeling better as soon as I bleed, I'm thinking vascular more than endometriosis. And if it's going bleeding really bad as they bleed, then I'm thinking, well, it's more direct endometriotic involvement. But so it turns out that if you can find vein, if you can say that there's a particular nerve that you think the pain's coming from, and the configuration, temporal nature of the pain is such that you think this is probably a vascular compression, you can go operate there. And you can laparoscopically expose the sacral nerve roots. You can expose the sciatic nerve. At least I can. But it took me years to learn how to do this, and I had to study with people that came up with the stuff in Switzerland. So it's like it was only maybe a couple of years ago that I felt comfortable with it. Maybe even a year ago that I felt really comfortable with it. And so, like, as interesting as this is, it's not scalable. Like, there aren't that many people that are like, there's only 2 people in the United States that have done this formal training, and maybe some other people that have kind of dabbled in it on their own. But that's kind of the problem, is that it isn't scalable to say, people think, well, I've got a vascular entrapment. I'm like, okay, but there aren't that many people that really know how to do it. It's quite dangerous because you're operating down in a deep hole with big blood vessels. And if it starts bleeding, it's hard to make it stop. And so a lot of people have absolutely no interest in doing that surgery. And when the videos came out of people doing it in the beginning, they felt like, oh my God, it looks extraordinarily dangerous. Why would you ever do that? And, it turns out that if you get good at it, you can do it safely, but it's actually quite a little bit stressful as a surgeon because you really have to be very correct in what you're doing. But it's an interesting thing. But I'd say one other thing, like, it works. Like if you diagnose the patient with the right thing and you go in and you find the vascular issue, I've seen some amazing results. I mean, when it started, I didn't know if it was real. Like I watched some of these videos and I said, like, okay, maybe that's bullshit. Like you see the vein, yeah, okay, it's compressed around the nerve, but was that really causing pain? Like the vein is supposed to be there. It's not like the vein is a birth defect. Like that's 10% of people have a vein like that. Is that really pathological? But I have had patients that came to me limping. Their sciatica is so bad, like 2 weeks out of the year they limp, or 2 weeks out of the month they limp. And that I went in and found a very tight vascular compression and removed it. And like 2 days later in the post-op, they just walk right into the office and say it doesn't hurt anymore. And I'm just like, oh my God, it was real. And in the operating room, I wasn't sure if it was real. I saw the vein and I'm like, okay, I'm going to do this, but is it going to work? I don't know. And sure enough, the patient's like, doesn't hurt anymore. And 6 months later, I had one patient that called me 6 months later. So I just did a 10-mile hike up a mountain. And before you operated on me, I could barely walk. And I'm like, all I did was remove some veins. It's fucking crazy. Excuse me, but it's crazy.
Yeah, I think for the vast majority of people, certainly in the US, I don't know what it's like abroad, treatment like that is not accessible.
No, it's not. And I don't want to oversell it either, because I just think that it's a small number of people that have this issue. I don't want.
Right. No, Andrea would say it for that patient that fits the profile.
Right.
That's when you begin to evaluate that. Dr. Zoland, you're nodding a lot. Any commentary there?
Well, I think your last point was the critical point, that even though it's not a large population that may have this, the history, and this just goes back to what we're all saying, it's really important to take a very detailed history. And for you patients out there, it's important to record and log your symptoms, when they come, find the pattern if you can, find what makes it feel better, what makes it feel worse, because a lot of these things then come down to, as long as you're telling it hopefully to a person that gets you to the next person that gets you to the right person, it was you giving us the information that let us come to the diagnosis. And that's the key point here. I think, all of these different syndromes that we're talking about, a lot of times, as long as you find the clues and you put them together with the patterns, and then you start localizing it to which nerves we're talking about, then you tend to have an answer. Again, we're not perfect. We don't always get it right. There are just sometimes we cannot figure it out, no matter who we are. But, that's the key point. The information coming from the patient, and the doc willing to listen, the doc willing to sit with you for an hour, go through everything and really listen. And, unfortunately, the state of medicine these days in the United States and probably everywhere, docs don't have an hour to listen. But, that's where the frontline people really are amazing. The PTs, the pelvic PTs, because you've got the time with the patients, and it's really important to give all the information to these people who can then guide you in the right direction.
Yeah, I mean, that's exactly why I changed the model of my practice. I mean, I practice out of network, because if I were to take in-network payments, you just don't have enough time. Like Dr. Zoland was saying, like you fill your practice with so many patients in order to pay the bills that you give them 10 or 15 minutes. And I spend an hour to an hour and a half, sometimes even 2 hours with a new patient. Like if it's really if I have a patient coming from out of town and I think it's kind of a neuropelvicologic issue, I'll see her for 2 hours. I'll block out 2 hours on my schedule for that patient, because it's just going to take that long. Like we're going to talk for an hour. We're going to do 30 minutes of an exam and complex neurological evaluation. and then we're going to talk some more, and then we're going to order some studies. Like it just takes a long time. And I think that people are quite critical of physicians as like not caring or not knowing, when the reality is that the system that most physicians work in does not allow them to be as good as they could be. Like I study this area and I find it fascinating, but if I had to spend 20 minutes with my new patients, I wouldn't be nearly as good of a doctor as I feel like I can be now. And so to some extent, as frustrating as it is, it's not always the physician's fault that they don't figure out your problem.
It's interesting, just as part of that, I've been doing a lot of research on burnout. I know your wife did a webinar, but especially on medical burnout, in that I don't think anybody went to medical school to sit in front of a computer and look at the screen and not the patient. And I think it's changing. It's changing who is in the field, but it's changing the way medicine is right now. And eventually there'll be an answer. Hopefully, like we can be part of the, part of the change, but eventually it is going to have to change, because I don't think we're going to retain physicians into the field if all they're going to do is basically be like, data entry for symptoms. There are certain aspects of medicine, certain specialties that aren't going to stick around, I think. Also, the payment system is really bad for that. Anyway, okay, so we are in, thank you, Dr. Fogelson, very much. Thank you, Dr. Zoland. So we are in our 5th year. The Endometriosis Summit is coming up March 24th through the 26th, 2023. And I am going to go around and ask everybody what they are looking forward to the most. All 3 of you will be joining us in one way or another. And Amanda, what are you looking forward to about the Endometriosis Summit?
I will be there in person, and I'm looking forward to seeing everyone. And I am looking forward to seeing some of the workshops. They always bring something new and exciting. You always take something new away.
Yeah, so this year we'll be having like a lot of PTs in the workshop, and we'll also do the science of pain, which I think everybody in this particular webinar will like. And that was at Dr. Vidali's request that I should find a science of pain lecturer, and I did. So there you go with that. Dr. Zoland will be joining us for a full leg pain panel on Sunday, March 26th. And some of the questions I'm going to go through what's here in the chat and what's online in Facebook and also on Instagram, and see if we can pull any of those questions for those panels so that they don't get left behind. But we probably have 40 questions over on Facebook we didn't even touch yet. So we'll have a lot to talk about on that panel. We'll have a full hour. Amanda will be on that panel, and we're actually going to be substituting out Dr. Fogelson with Dr. Mangashikar, because Dr. Fogelson will be joining us on the 24th with a discussion on neuropelvicology. Dr. Zoland, what are you looking forward to about the Endo Summit this year?
Same thing I look forward to every year, which is just the open conversation, getting new perspectives. I'm learning just like everybody else. And I think the more we communicate, the more we learn, the more we hear from the patients. It just makes us better equipped to, try to deal with this stuff. And I just think you guys do an amazing job with that.
Right. So one thing that we take from Dr. Zoland is we never wanted to have like the PowerPoint lecture format. And he sort of pointed that out to me late in the summer. So that's why we created what's going to be our fireside chat, which will be sort of like not a video contest, but that the doctors in those particular topics will be able to converse with each other and the crowd through their own surgeries. It'll be very interesting. Instead of having somebody stand in front of you and give a PowerPoint presentation, that's what we'll do. And Dr. Fogelson joining us for the Endo Summit virtually this year. What are you looking forward to about the summit?
Well, I always enjoy. I've been virtually in the last couple of years. I was hoping to come this year, and then it turned out my daughter's school spring break was the same weekend, so we didn't quite work out. But it's just a great program that you guys have created, and it's just amazing how much it's grown. And I remember at AAGL there was a number of endo patients and advocates that came to like the endometriosis SIG, which is a special interest group, and kind of wanted to contribute and wanted to say some things as they should. There they are. And I remember a lot of the kind of old school doctors were just like, what the hell are you doing here? Like,
I
this
wonder
is really...
if that was the year there was a complaint. There was a fully filed complaint that all the advocates were in the room. And they actually cited me, and the answer was, she was presenting. You can't throw out a right. But
there was a couple times, and I kind of, this old school idea that like talking about this disease is for doctors, it's not for patients, and patients should just listen to what the doctors say. And it's like, no, that's BS. And you got to really listen to patients and have them tell you the stories of what's going on with them and understand how much it impacts them. So I'm glad that there is sort of this environment where physicians and patients can kind of and patients and PTs and everybody can kind of be on an even playing field, and we're just all there to talk about this thing, and everybody has something to say.
It's
so
interesting,
I think it's good.
Dr. Arrington will talk about, is paternalism in medicine dead? And I think that's that notion of, I'm the doctor, you listen to me, you don't contribute, and that'll be interesting because I read his notes already. So I know some people send their stuff early. So for everybody that's wondering why I keep looking that way, on puppy training, you should only know what's going on to the left of me. It's like, you should only know at this point. And that's my whole, you think by March, the puppy will be trained? I don't know. So tickets are on sale.
A couple years.
Yeah, a couple years. I don't know if I could take a couple years of this. So tickets are on sale for the Endometriosis Summit. We hope to have Amanda back on an Instagram Live, and we invite Dr. Fogelson and Dr. Zoland to join us for an Instagram Live as well. This Wednesday, January 11th, we will be on with Dr. Olson Tricandi talking about vulvodynia and its link to endometriosis, which I think, and she has research backing that. So I think that should be tremendously fascinating as well. And next week, we are on with our keynote, Jillian Gilchrist, I believe, that is next week. And that will be about politics and legislation and endometriosis and where we're heading for the future and what you can do about it to head that way. So take care, everybody. We'll see you next week. Thank you. Thank you so much, doctors.
I enjoyed it. Thank you.
And Amanda, take care.
Sallie.
Thank you.
She's a doctor too.